this, and we want to appreciate Dr. Khaitov for joining us this evening to speak on such an anticipated topic. We want to say that all lines are muted, and the lines will be unmuted after Dr. Khaitov has finished his presentation. So we'll give a 10 minutes time where you could ask questions, and we're happy to say that Dr. Khaitov will be here to answer as much questions as we have. We also want to emphasize that as you come into your clinic visits to see your physicians, please kindly take your patient report along with you so that you could discuss the checklist of care and your quality metrics. I will be handing over to Dr. Khaitov to make his presentation, and please remember that all lines will be unmuted after his presentation for questions and answers. Also, you can also type in your questions, and then we'll be able to see it and we'll respond to you as soon as we get them. Thank you very much. Dr. Khaitov, I'll be handing over to you now.
Hello.
Hi, Dr. Khaitov, we can hear you.
Oh, you can hear me?
Yes, we can hear you, sir.
That's awesome. First of all, I want to apologize for delay. I actually was doing surgery for ulcerative colitis patients, so I just finished the surgery. So now I just have to share my presentation screen. So if you can guide me through, or just click on share screen.
Yes.
Okay. Okay. Okay, here we go. We actually share the file. Share options. Microsoft PowerPoint. Okay. All right. Can you guys see my?
Yes, we can see your screen. Thank you.
Okay. So did you guys go through introduction or something?
Yes, we have, but if you could please just introduce yourself again, because we have so many people online that are listening, so that they could...
Okay, great. So my name is Khaitov. I'm one of the colorectal surgeons at Mount Sinai Hospital, and my main specialty in colorectal surgery is actually surgery for patients with inflammatory bowel disease, with ulcerative colitis and Crohn's disease. And today I will be more than happy to tell you about ulcerative colitis surgery, and I will be more than happy to answer questions you will have. So that's my brief introduction. Okay. Hello?
Yes, thank you, Dr. Khaitov, for the introduction. So we are waiting to hear your slides. We want to appreciate each and every one of us for joining us this evening. And please note that all lines are muted now, and we will mute the lines as soon as the presentation is finished for your questions and answers. Also, please, you can type any questions you have on the question section in the tab, and then we'll direct all questions to Dr. Khaitov. Dr. Khaitov, over to you, please.
Okay, thank you very much. So today I will talk about chronic ulcerative colitis, or CUC, and I will start with indications for surgery, or why we do the surgery for those patients. And there are three major categories when we actually do the surgery. So there are people who come to the hospital who are extremely sick, who have so-called toxic colitis or life-threatening complications from their ulcerative colitis, like they are bleeding out, they need blood transfusion, or the bowels rupture and they perforate. So there is not so much discussion whether surgery has to be done at that point. It just has to be done to save life. The other big situation which we face is when the patient has long-standing history of ulcerative colitis. Sometimes there is a complication with development of cancer or precancerous condition, which is called dysplasia, which most of the times will require surgery. So in that situation also, the discussion is relatively easy. You don't do surgery, you pose risks of cancer to yourself. So we do recommend the surgery. And most common indication why we do surgery for ulcerative colitis is so-called failure of medical management. And most of the time, this is the situation when patients was started with one medication, then goes to another medication, combination of medications, biologic agents like Remicade or similar medications, and in certain patients, those medications will stop working or will not work enough, and that is the majority of the cases we will be performing surgery. So surgical options are various for ulcerative colitis. They, most of the times, will include 3, 2, or 1 surgery with so-called restorative proctocolectomy. Most of the times we mean by saying the restorative proctocolectomy, we mean complete removal of the colon and rectum and creation of the J-pouch. As you can see, it can be done in 3, 2, or very rarely in 1 stage. When I say no, means most of the times we really try to avoid one-stage surgery for ulcerative colitis with J-pouch. And the other option, which is very common for maybe older patients, maybe patients who have injury, previous injury to anal muscles or anal sphincter muscles, or who suffer from incontinence, those patients may choose not to do J-pouch, or they may not be good candidates for J-pouch. Then the treatment is total proctocolectomy, means removal, complete removal of colon and rectum with creation of the permanent bag or permanent end ileostomy. Now, the older versions of surgery, which we used to do at some point, but we stopped doing this most of the times, so-called cock pouch or continental ileostomy. You can see the picture, and we really discourage most of the patients from this type of operation. There are very few surgeons in the world who still will do this operation. Unfortunately, the risk of complications and need for reoperation with this approach or cock pouch approach is very high, and it is not recommended. The other operation, which used to be done about 15, 20 years ago, when we removed most of the colon, but we did not remove the rectum, and we connected the small intestines or ileum to the rectum. So the surgery was called subtotal colectomy with iliorectal anastomosis. We don't do this anymore because it just doesn't seem to work. The patients who had this operation for ulcerative colitis, it is about 50% or 60% chance that they will end up needing the rectum to be removed. So this just does not work long term. So overwhelming majority of the times, we will do the surgery with the use of minimally invasive technique or laparoscopy. So that implies that we will make a small cut on the abdominal wall. We'll put a video camera, which is called laparoscope, inside the belly, and we use the instruments, which are like the chopsticks in a sense, to identify the organs in the stomach, inside the belly, and remove colon and rectum with the use of laparoscope. Still, we have to understand that there is certain incision made on the abdominal wall, first of all, to introduce those instruments. Number 2, to deliver the bowels out, so we need a little cut, and to create this, the ileostomy. So there are certain cuts on the abdominal wall, so it's not incision-less surgery, but most of the times we can accomplish the operation with laparoscopic technique when we have really smaller incisions as opposed to open surgery. We have to remember that the laparoscopy may need to be converted to regular open surgery should any problem occur, like the scar tissue, difficulties during the operation, bleeding, or God forbid some sort of complication. Luckily, this is not a common situation. So the proctocolectomy, as I mentioned before, that's removal of entire large intestine, starting from appendix, right colon, transverse colon, descending colon, sigmoid colon, and the rectum. The anus stays in place in patients with restorative proctocolectomy. So you can see this is a picture from the operating room from a few years ago. So this is exactly what we see on this painting. So this is the appendix. This is the very end of the small intestines. This is this so-called ileum. That's where we will start to make the J-pouch. So it goes from the right colon, transverse colon, left colon, sigmoid colon, we don't see much of rectum here. You can see that blood vessels here are disconnected, so the colon is completely free from the patient's body. So inside the stomach, what we see with the laparoscopy, we see the, like a picture. It's like in a sense, it's in a sense a video game, and we operate with a picture. We see the screen, and our hands are visible in a sense with the instruments. So if this will work, okay. So we'll go with the next slide. And we assess during the surgery, we assess how the colon will move. Unfortunately, my videos in this presentation are not working. But basically, with the use of instruments, we free up the colon, as I showed you completely, in order to remove it, and then create the J pouch, and then create the diverting ileostomy, or the bag on the right side. So when we look at the very end of the small intestines, you can see that this is the ileum, where it connects to the large intestines. So those short lines are the lines where we divide the blood vessel, and we pull. This will be the apex of this letter J, and that will be the J pouch in the future. So we take this portion of the very end of the small intestines to pull down towards the anus to connect it. And I will show you in the next slide how it looks in real life. So this is the small intestines. Those are those blood vessels. You can see them, which we'll have to separate. And then this area will be the apex, or the tip of the J pouch, which will go towards the anus. So this is how it looks actually when we do the surgery. So we take the very end of the small bowel, we fold it in the shape of letter J. We use special machines to create the sac or cavity, which is called the J pouch. So this will be a reservoir which contains the stool, and it works instead of patient's rectum. So it will accumulate the stool and will empty it when the time is right. So we use the special staplers. So then, when we remove the rectum, it's very important to remember that we usually, most of the times, we will save the very last 1 to 1.5 inches of the rectum, which is the anal canal and muscles, or sphincter muscles. So those muscles we will preserve. This group of muscles, you see this, which is inside, this is called internal sphincter muscle. This is so-called internal sphincter muscle, and we preserve that. And this is the external sphincter muscle. The function of the internal sphincter muscle is to maintain continence while we are asleep. We don't have real control over it, but it's always contracted. It relaxes only when we have to defecate. Now, the external sphincter muscle is something which we can voluntarily control, and we can squeeze our anus when we want to. So we have urge to defecate, but we are, let's say we're in the middle of hallway and we're not ready to do that. So we squeeze the external sphincter muscle, and we prevent ourselves from accidents. So that way we go and find the right place and go to the bathroom. So sometimes we remove the very end of the patient's internal lining of the rectum. So that is called rectal mucosectomy, to connect the J pouch to the anus. And that's a very fine procedure, which is not done commonly. It's safe to the patients who have very bad inflammation of the very end of the rectum. It's not done by the vast majority of the surgeons, but we have to be ready to do this, to remove the very end of the internal lining of the rectum. So this is the picture how it's done. So basically we take the internal lining of the rectum and separate it. And while we preserve the muscle, you see this is the muscle, and this is the muscle. We don't touch that. And the J pouch will be sutured eventually. So we move more. This is the mucosectomy. And the J pouch will be sutured through the anus. You see the internal lining of the rectum is removed, and it's sutured. And then the other technique, the alternative technique, it's so-called staple technique, using the machine. So when we leave in place one last inch of the rectum, and we cut everything above out, so this portion of the rectum above this last part, which is called rectal cuff, is saved. So then we connect with a special stapler. We connect the J pouch to the rectal cuff. This is how the stapler looks. And basically it creates two circles of the titanium staples, which are looking like letter B when they are formed, and they hold the pouch in place until it heals. Those staples stay with the patient forever. They are made of titanium and they're intact, so they're inert, so they don't bother the body of the patient. Okay. So we do this laparoscopically, as I mentioned, so we free up the colon. You can see actually the picture of the colon, how it looks when it is inflamed in the patient's body. Those are endoscopic scissors. We cut the surfaces of the attachments of the large intestines. You can see how the intestines are inflamed. So this is thickened, and you can see how the colon has those little bright red spots. Those are newly created blood vessels. That's the result of chronic inflammation. So sometimes we can finish with the incision, which looks like a cesarean section incision. Nowadays, we actually can avoid even this. So the patient may not have even that incision. The only incision they will have, like small cuts here, and the cut from the ileostomy, the scar from the bag. That's what we do most of the times. So those are potential incisions. We try to avoid even that right now. Now, when we do the surgery, there is need, when we finish the surgery, patients wake up with urinary catheter, and it stays for a couple of days in the patient's urinary bladder. The idea is that after removal of the rectum, not everyone will be able to urinate immediately. What happens when we do the surgery there, we kind of like shut down the nerves for a couple of days and wait until they recover. There is need for the tubes coming out from the stomach. Those tubes are called JP drains. They are sitting in all the way down in the pelvis, and they are helping us to monitor what kind of fluid is coming out from the abdomen, just to make sure that there is no infection. Sometimes, not always, we have to leave so-called rectal tube, and that's a kind of like a hose, which is inserted into the anus. Everything is done under anesthesia, and it is basically, the intention of that is to decompress the pouch. We don't always use it, but sometimes we have to, so every patient will get information about those tubes. To go home, patients will go home without any tubes, obviously. We have to mention about risk and expectations. What do we get with the J-pouch surgery? So, there are obviously risks of general anesthesia, but those are inherent risks with any surgery in the abdomen. And also there is possibility for risk of any abdominal or pelvic surgery, not necessarily J-pouch surgery. So it's a small bowel obstruction, hernia, or abnormal bulge through the abdominal wall from poor healing of the incisions. Bleeding, which is very rare, but it's a possibility. Sometimes may require blood transfusion. Injuries. During the surgery, there is small but real risk of the injury of the organs we didn't plan to operate. There are certain risks clearly associated with just J-pouch surgery. So it is infection in the pelvis or pelvic sepsis. Some patients may need an ileostomy, and sometimes they may need it for life. So this operation is not a guaranteed success. Generally, we describe the success of this surgery about 95%. Most common complication of this surgery is so-called pouchitis, or inflammation of the pouch. It may happen in about 1/2 of the patient. The good news, despite it's common, usually it's very easily treated with oral antibiotics like metronidazole or flagyl or ciprofloxacin. Stricture or narrowing of that connection of the J-pouch, very common but easy to handle, sometimes may require minor procedure to stretch it in the operating room. There are bad complications like infection or fistula when there is abnormal connection between the pouch and surrounding organ, like tissues around the pouch. That's called fistula. That's a pretty severe complication which may eventually lead to loss of the pouch. Damage to the nerves may lead to sexual dysfunction. The actual rate of damage to the nerves leading to sexual dysfunction in males is about 2%. Ladies may develop infertility as a result of the surgery. The problem is that anytime we do the surgery in the stomach, especially in the pelvis, we cause patient to develop scar tissue. It's inevitable result of any surgery in the pelvis and inevitable result of removal of the rectum. The good news is most of the ladies will be able to become pregnant, but they may require in vitro fertilization. Overall, the decrease of the rate of unassisted pregnancy after J-pouch surgery is described as being 50%. So the decrease is 50%, which is quite significant. Some patients will require reoperation after J-pouch surgery. The risk of that is not high, but it's real. As I said, that patients may lose the pouch or pouch may fail. Overall, long-term is about 5%. Sometimes that needs to be excised, and that is a big surgery, and end result of that is permanent ileostomy. Rarely we may redo the J-pouch, but those operations are done on case-by-case basis, and they don't always work well. Very rarely, patients may develop cancer or precancerous situation in the pouch. We do recommend after J-pouch surgery every year to examine the pouch with a pouchoscopy, surveil the pouch. Important things about the female patients. So let's say they do the J-pouch and they become pregnant. We do recommend that patient will have cesarean section delivery. The story with that is that it is possible to deliver vaginally. It is definitely possible. The problem is sometimes there are complications of vaginal delivery, and that may lead to ruptures, specifically ruptures of the sphincter muscles. So that will completely defeat the surgical goal. So if the patient has a J-pouch and has ruptured muscles, that will be a really, really bad situation. So we do recommend cesarean section, which is uniformly successful, and we just coordinate it with obstetrician. Couple words about pelvic sepsis. So that is infection in the pelvis as a result of usually poor healing of the connection of the pouch, and it may lead for bad function of the pouch and stricture or narrowing of the pouch. It may lead to higher risk of infertility in ladies, and it leads to reoperation. Very rarely it will lead to death. Now, that pelvic sepsis may require loop ileostomy. So when we do the J-pouch, we protect it with the bag upstream of the J-pouch. That means that the stool immediately after creation of the J-pouch will not reach that area, so it will allow it to heal better with less risk of infection. So we do recommend diverting loop ileostomy. That refers to the same statement I made before. So we don't recommend one stage or J-pouch without any ostomy. So that is a rare situation which we usually do not recommend. Some surgeons still do it, but we try to stay away from that. Ileostomy may lead to complications on its own, like blockage or obstruction, dehydration, hernia, and trouble with the application of the bag and irritation of the skin, and obviously a reversal of the ileostomy or last stage of the J-pouch operation. It is additional surgery, but still most of us believe that it's a worthwhile to do it protected and reliable way to avoid future complications. So we do recommend laparoscopic surgery for overwhelming majority of our patients. That's what we're striving for. It's not necessarily the case, but we want the patients to have less pain. We want the bowel function will return earlier because they need less narcotics. We want to send them home early. We want our patients to come back to work earlier. That's what we expect from laparoscopic surgery. And what we expect from the pouch when it's made, we have to remember that pouch is not exactly the rectum, which was not disease. So it's not the same when we describe pouch function. Patients with successful pouch surgery will have 5 to 7 bowel movements every day. Rarely will have 2 to 3. If my patient with J-pouch comes to me and says, oh, I have 2 bowel movements a day, that will make me a little bit worried, so I will be looking into it and try to see if there is any problem. Usually I expect to have 5 to 7 bowel movements a day from average patient. Some people will have 8 to 12, and not everyone will be bothered by that number. We have to remember that with the J-pouch, it's kind of like a new normal. It's different from something before disease and some normal rectal function, but it's not completely abnormal, if you will. So we expect the patients with successful pouch surgery eventually have perfect continence. Little risk, small risk of near perfect continence. So some people will need napkin or pad for seepage or nighttime seepage. That's most of the times nighttime event. The stools are soft, usually toothpaste consistency or watery. They are not formed stools. There are different defecation patterns. What I mean by saying that is that a lot of patients will go to the bathroom, sit on the toilet commode, and will relax their pelvis and urinate and defecate at the same time. It's just easier. It's not they cannot separate the urination from defecation. It's just easy for them. So that's what most people describe, but they can definitely do things separately. It takes about 4 to 6 weeks for true recovery after J-pouch surgery when everything is done. You will be able to do home things like, everyday activities pretty much immediately after discharge, provided there are no complications. But for true recovery, it takes about 4 to 6 weeks. And the pouch, it has to mature. We assess that it takes about a year for the pouch completely mature, so it takes a few months before the pouch matures, and the number of bowel movements at that time will slowly go down. From maybe some people will start with 8, 12. They will start taking Lomotil or medication to slow down the bowel movements, but eventually they will come to equilibrium or this stable situation when they have 5 to 7 bowel movements a day. So that's what we want you guys to be very active, and those are some professional athletes. This patient of my partner who is professional athlete and who has a J-pouch. All right, the other options besides the J-pouch, I will just mention that briefly. It's a total proctocolectomy. So that's for patients who sometimes are older, the muscles don't work, sphincters don't work, or sometimes patients may have cancer in the lower rectum, and we will have to remove entire colon and rectum, and patient will end up with a permanent end ileostomy. That's how the ileostomy looks, or bruchiliostomy. When we look at that, it's a portion of the intestines everted outside. It comes through the abdominal wall. The patient cannot control the bowel movement, and that the appliance or bag is attached to the skin on top of this. Again, as I mentioned before, there is no role these days for cock pouch or continent ileostomy. So usually for patients who cannot have a J-pouch, we would do most of the time total proctocolectomy, or complete removal of the colon and rectum. All right, and I will say that that will end my presentation, and I will be happy to answer questions should people should you guys have questions. Go ahead.
Thank you so much, Dr. Khaitov. We really appreciate you enlightening us on the surgical management in UC. I want to appeal to everybody on the line. Please, I'm going to unmute the lines now. If you have any questions, we appeal to you. Please do not use your names so that we could remain anonymous. We're going to unmute the line for the next 10 minutes, so please feel free to ask your questions.
Hello?
Yes, so all the lines have been unmuted. Please feel free to ask your questions, and Dr. Khaitov will be waiting to answer them. Quickly, I see some questions have already been typed in. Dr. Khaitov, I could read some of them so that you could give
Okay, let me just, let me see, because I believe that my WebEx just logged me out, which is great, but hold on one second. Share, hold on one second. I have to, I believe I have to relog on to my WebEx. Give me 1 second, because it just kicked me out.
Okay, while we're waiting for Dr. Khaitov to log
Yeah,
on.
if you could start reading me the question, or someone may be like asking questions.
Sure.
Uh,
So
just,
one of the questions here says, when is surgery necessary and what makes a good candidate?
okay, so to be a good candidate for surgery, most of the we want to make sure that patient truly exhausted. We want to make sure that the patient exhausted medical options. So the decision to do the surgery on someone, omitting the situation when the patient has cancer or emergency, is done also with help of gastroenterologists. So gastroenterologists should tell us that, look, we tried several medications, we don't have good options in my pocket to add to reverse the course of disease. Now, what makes people good candidates? Most of the times, being young is a good thing, number one, but that's not necessarily a universal statement. We've done J-pouches for patients who are 60s and older, but we have to remember that it just does not refer to biologic age, to chronologic age. Usually we basically refer to biologic age. We have to have good sphincter muscle function. So the patient, we usually at the office will check the muscles. So we'll ask the patient, we do rectal examination, we'll ask the patient to squeeze, and usually we can assess the muscle function. Now the other thing is that patient should, for the patient to be good candidate, is to not to have Crohn's disease, which is one of the concerns that patients who may have Crohn's disease or had anal infections in the past, like abscess or fistula, they are not good candidates for J-pouch surgery because the failure rates are really higher in patients with Crohn's disease. Rarely we do J-pouch for Crohn's patients, but most of the time it's not a great idea. Now, yes, entire colon needs to be removed. That's the idea of the surgery. We may or may not leave very tiny portion of the very end of the rectum, so-called cuff. That's the only thing which stays. So entire colon needs to be removed. Unfortunately, in the past, it was tried to remove portions of the colon, but it just didn't work. Complications of surgery are numerous, and they're multiple, and some of them will require reoperation, some of them will not. The most common thing, as I mentioned, the most common complication of the surgery is so-called pouchitis, and that is when patients develops inflammation of the pouch, in the pouch. We don't know why this happens, and what usually patients will describe that they had those 5 bowel movements a day and they were doing great and they were very happy, and then all of a sudden they feel belly cramps and they run more to the bathroom and they say, oh gee, my colitis is back, what's going on here? So they will call me, and very often I will tell them, oh, it may be pouchitis. Take orally antibiotics. Take Cipro or Flagyl, and sometimes I can even handle it over the phone, and overwhelmingly it will respond to antibiotics, and those symptoms will go away. Again, I gave the big slide of the possible complications. There are many, many, but again, just to remind that studies which were done nationwide say that we have 95% success rate, and patients who had this type of surgery, in 95% of the times would recommend the surgery to their friends and would answer the question if they would go through the surgery again. They said that they would. So it's considered to be very successful surgery. The surgery, the so the surgery for the J pouch, depending on the circumstances, it will take about 3 to 4 hours. Now, the procedure does affect pregnancy. I mean, it affects pregnancy in two spots. Means that ladies who want to become pregnant, they unfortunately will have a little bit lower chances to become pregnant without assistance. And when the delivery comes, when the baby is ready to be delivered, we do recommend elective cesarean section. We do not recommend vaginal delivery. It is possible to deliver vaginally, but we are very afraid of the damage to the sphincter muscles to control the bowel movements, which will basically defeat the surgery completely. Go ahead with more questions.
Thank you so much, Dr. Khaitov. Please note that the lines are still opened. If you have any questions, feel free to ask them. A question just came in. It says, how long does it take to maintain full function after the surgery?
Okay, so I see another question. I did. Can one live a normal life after the surgery? The answer is absolutely yes. That's our goal. That's our goal. And most of our patients would tell us that they got their life back from being very, very sick. It does take surgical approach. It's not easy way, but we do, in overwhelming majority of the circumstances, for the right patient, we do have good results and patients are doing well. Don't take me very easy that we don't recommend surgery for everyone. We have to remember, as a surgeon, I see patients who are not well. I see the patients who are referred by GI doctor who failed medications. I see maybe 20% of all the patients or less, the patients with ulcerative colitis. So have to remember, most patients with ulcerative colitis actually will be doing very well. So I see just the portion of the patients with ulcerative colitis, but I usually will see the most miserable patients, and overwhelming majority of the times we can make them much, much better. All right. I think we saw that does it affect pregnancy. We spoke about this complication, entire colon, when surgery. Okay, and can one? All right. Any more questions?
Thank you so much, Dr. Khaitov. I believe all the questions that have been typed so far has been covered. We're going to leave the line open for 1 more minute. If you have any other questions, feel free to ask.
I just want to say something else. That one thing I do recommend to my patients, first of all, to make the decision to do the surgery, obviously patients will have to visit me at my office, and usually it's a fairly lengthy visit. It's not 5-minute conversation. Usually we have to sit down together to talk about this again in probably even greater details and make sure patients really truly understand what they're going to have done. And I will again answer their questions, show them more pictures, more education. And again, if the situation is right, overwhelming majority of the times, patients will do very, very, very well with acceptable risk. And, okay. All right, so here's the question. Surveillance of the cough and how long-term, okay. So, very good question. So we do recommend yearly surveillance of the cough. The reason is that there is a very small portion of the rectum left behind. It may have mild inflammation. Usually, if there is severe inflammation to begin with, we try to remove that area by virtue of doing mucosectomy or doing hand-sewn anastomosis. Now, important to remember, hand-sutured anastomosis cannot always be done. If you look at the country, 95% of surgeons will do stapled anastomosis. And some surgeons will still do hand-sutured anastomosis. It has been shown that stapled connection of the pouch may have slightly better function after the pouch is made. So basically, patients with hand-sutured connection of the pouch may have slightly higher risk of seepage or leakage after the surgery. Nevertheless, they will not have inflammation in the cuff. So when do we have difficulties to do this hand-sutured anastomosis, let's say in obese patients, or some patients have they're really short stature, so they are not tall. Sometimes it may be really, really difficult to do hand-sutured anastomosis, and we are forced to do stapled anastomosis, or the patient may choose not to have a pouch, which is really not a desirable situation. Risk of cancer in the rectal remnant or in the pouch long term is extremely low. Most of the times it's risk for the patients who had pre-cancer situation before the pouch was made. So it's very, very rare, really extremely rare, I would say, that patients may develop cancer in the pouch or in the rectal cuff when the patient did not have pre-cancer situation before the surgery. I hope that answers that question.
Thank you so much, Dr. Khaitov. We want to appreciate each and every one of us for joining us this evening. We know our time is fast spent. We just want to use this medium to say that if you are having more questions, we want to ask permission from Dr. Khaitov. We would like to share your contact information for your office in our next newsletter, because we believe there are patients who might want to reach out to have further discussions. Sure. And so with your permission, we would like to share your information on our next newsletter. And also we want to appreciate everyone, and we want to say that this webinar has been recorded, and it will be sent, the link will be sent in the next newsletter. So even if you have missed it today or you want to listen to it all over again, please watch out for our next newsletter, and you have the link to this webinar. Next webinar. Yes, Dr. Khaitov.
Yeah, I just wanted to add, obviously it's not all-inclusive discussion, and overwhelming majority of the times we'll have lengthy meeting with the patient, and obviously if someone has more questions, they should feel absolutely free to call my office, and we may talk about this more. Should you need more information, you can make an appointment to see me, and we may discuss this obviously in more details, and I will be more than happy to answer further questions.
Thank you so much, Dr. Khaitov. Just as everyone has heard, please, if you have any other questions, I believe some of us will want to meet with Dr. Khaitov. So what we'll be doing is we'll put his contact info in the next newsletter. If you want to reach out to him, please, you can reach out to him through that contact info, and he will be happy to assist you. Our next webinar will be on the 3rd of October. We'll be having another speaker come to speak to us. We will share the newsletter showing the topic and the time. We want to appreciate each and every one of us this evening. Once again, we thank you, Dr. Khaitov, for taking out time to explain the surgical management of UC to us. And we say good night to everyone. Thank you.
All right. Thank you very much. Thank you. All right. Bye-bye. Have a good night. Bye-bye.